Yes, Dr. Gaurav.
Are we ready to go live?
Yeah. Gaurav, please.
Yes, sir. I'm just sharing my screen.
Live, sir.
So is my screen visible to all?
Yes, yeah, your screen is visible. You need to be a little louder, Gaurav.
Yeah, so is it okay now?
Yeah, we can see it.
Great. So it's an honor to introduce Shital sir, and we are following whatever he is teaching us in pediatric sports injuries. And whenever I am stuck in my cases in pediatric trauma, I always reach out to sir, and sir is very kind to respond me on WhatsApp. Thank you, sir. So sir is a professor at Cincinnati Children's Hospital. Sir has done his master's from Ahmedabad, as Molin sir told, and then Shital sir did multiple fellowships in Canada and US. His interests include patellar instability and pediatric ACL tears, apart from other pediatric sports trauma. Sir got a Patellofemoral Fellowship Award in 2013 and 14. He has published extensively in pediatric sports medicine and is an editor of Pediatric ACL and Patellar Instability book. He has been on editorial board of orthopedic clinics. He has been on the editorial board of Chinmay. Can you mute the participants, please? He has been on editorial board of Orthopedic Clinics of North America and Orthopedics Today. He is the IFIX faculty. He has presented his work at various national and international meetings. He has been involved in teaching activities at courses and annual conferences and has organized several international surgical mission trips. So with this brief introduction, I would invite Shital sir to take the talk. After the talk, we'll take all the questions. So anybody who has any question can put it on the chat box, and we'll take those questions after the talk. And then we have one interesting case by Sheenam. So Shital sir, please start the talk.
Can you see my screen?
I'm just stopping my screen share, so you will be able to share now. Yeah, now we can.
Yeah.
See you. Great.
Can you see the screen? Okay.
Yes, sir.
And you can hear me fine, right?
Very
Yep.
well, sir.
Yes.
Okay. Yeah, I'm glad to be here. Talking with everyone here. I hope that this would be a little bit more interactive. So thanks, Molin, for the invitation, and Gaurav for the introduction. I always enjoy, talking about pediatric trauma. And as Molin said, I would recognize our mentor, Dr. Pankaj Divetia, who, passed away a few years ago. He's the one who introduced us to nailing, though at that time we used to use Ender's nail and not the elastic nails that we currently use. But he was a big fan of nailing compared to plating for several reasons, including cost and low rates of infection. We did nailing for almost every bone and every fracture, every long bone fracture, including intertroch fracture. We used to do Ender's nailing for those as well. So we were very fortunate, from that from that standpoint, we were fortunate that we got introduced, and we had a lot of experience with nailing coming out of residency. But at the same time, the downside was that we hardly did any pediatrics. So as Molin said, even though we practiced pediatric orthopedics, it was after the residency that we got trained in peds. But I would like to acknowledge him for all his teaching. So Ender's nail, I just brought up the topic. It was introduced in Steyr in Austria. And this is the original article from Ender. The issue with the Ender's nail was that there is an eyelet which makes the nail very prominent. Those were stainless steel implants. So there was significant difference in the rigidity of the implant versus the pediatric bone. The principle of stacking means that you had 3 or 4 nails, which made the nails even more prominent. That means that there were issues with, skin necrosis, prominent implants, and angulation at the fracture side, because most of the nails were introduced from one side. And then the good things about Anders nail, it was very easy to remove because of the eyelet. They were very cost effective because they were stainless steel nails, and they were readily available. So we used a lot of Anders nail during our residency, and this was publication from 1970. And then the Nancy nail was introduced in Nancy, France by Mattezo, who also introduced several other things besides the nail, their Mattezo techniques. This is the original book that was published by Mattezo. This is the first patient that they did in 1979, and this was using the nail but not the principles of elastic nails, because you can see there was stacking of the canal. There were 3 nails used, and there were probably maybe even 4 nails, not really sure, 3 or 4, and then from both sides. So not exactly balanced nail principle, but this was the first time that it was used in a patient. And then Lescombs later propagated, translated the book into English. This is really a good book. If you're doing a lot of nailing, I would recommend that you read this book, or at least go through it. Several examples, and they use elastic nails for almost every fracture, including supraconda fracture, as shown here from the book. I've taken some pictures, and they use it for metacarpal fracture, phalangeal fractures, as you can see here. So a lot of extended indications of using elastic nailing. And we looked at our complications, because I'm always interested in the complications of a technique or of an implant. And there were several complications. So my talk is mainly a compilation of all the complications that we have seen. We'll go through each category, and so that would bring out the underlying principle of Anders nailing. So as far as the fracture selection, some of you may have seen the case because I've presented this at IFIX in the past, but for those who have not seen it, these are interesting cases where there were some complications. So you can learn from these mistakes. So here is a 12-year-old male who was wrestling. His weight was 35 kilograms, so well within the tolerance limits of 50 kilograms for nailing. The only thing that is unusual here is the spiral or long oblique nature, along with a very high extension of the fracture. And so it's considered to be a length unstable fracture. We used 2 nails here, 3.5. On table, it looked fine, but 3 weeks later, the patient had 4 centimeter shortening, and the nail had backed out. So the thing is this something that we can, allow to heal and then later on address it? We can, but that would require lengthening. So at 3 weeks, if something could be done to bring out femur to length would be ideal. A few things that could be done. One is what was done here is used a plate that was used in a submuscular fashion just to bring it out to length. Other things you can use is an X-fix, or you can do an X-fix with elastic nail right from the outset when you're putting nail if you think that it's going to collapse. So the ideal indications are length stable fractures, diaphyseal fractures, and weight less than 50 kilograms for femoral fractures, and age less than 11 years. Though these indications are kind of guidelines, and once we start doing more nails, then certainly the guidelines are kind of fuzzy, and we extend our indications quite a bit. Here is an extension. If you look at the AAOS guidelines for femur fracture treatment, then up to 5 years, the spica cast is what is recommended. But lately, at least here in the US, for preschool children that is 2 to 5 years age, there is increased use of flexible nailing. And the cited advantages, this article is still not published, is an online, just this month it came out. And it shows faster return to normal activities with nails, 40 versus 47. Now you can debate how much difference would it make, getting to normal activities 1 week earlier. But lower incidence of malunion, again, in this age group, things are going to remodel, so may not be too important. And it did require longer hospitalization by 1 day with nails compared to spica, and then it required 2 surgery. One is to put the nail in, and second one is to remove it. So whether it's worth it, depends on where you practice. Spica cast is still a great treatment, but just letting you know that flexible nailing, the age has been extended, to the normal recommendations. So this is a 2 to 5 year age group. For tibia nailing, there has been no difference in the outcome between younger or older, heavier or lighter kids. So basically, skeletally mature patient, if you think is unstable, you can choose to use elastic nails for the tibia. So in femur, the issue is that if the patient is really heavy, or older patients have a higher rates of malunion, but similar things have not been seen in tibia. So there is no higher limit. So, we'll go through some cases where when you would do a rigid nail for tibia instead of a flexible nail. Here is, a publication from our Indian faculty on elastic nailing with X-fix versus bridge plating in comminuted pediatric femoral shaft fracture. And they did a comparative study, and you can see that right from the beginning, they put an X-fix on, so that especially if you have a length unstable fracture or a segmental fracture where you think it might collapse, you can put an X-fix on it till it consolidates, which may be 3 or 4 weeks, and then you can remove the X-fix. So they compared this with the bridge plating, and so this is also an option for length unstable fracture, is to plate these fractures. When they compared the 2 groups, they did not find significant differences. And there were some pin track infection with X-fix, some nail prominence, and with plating, there were deep infections. So what you would expect with the routine surgery is nothing unusual, but both were equally effective and acceptable treatment options. When we look at, what are the risk factors for malunion or for issues with loss of reduction in these fractures, these articles summarize it. And if you look on the right side, the common theme is when the fractures are not in the mid diaphysis. If they are proximal, like subtroch fractures, or if they're distal, like supraconda fractures, then you don't have that balanced nailing principle, which can be applicable. And these fractures do end up with some malunion or loss of reduction. Same with combination or mismatched nails, which is against the principle of elastic nailing. Both nails have to be the same size. We looked at a 6-year period where we looked at elastic nailing for pediatric subtroch and supraconda fractures to see how we did, and it was similar to previously published series. We looked at 36 subtroch femur fractures, and you can see that almost 1 in 5 patients had one of the complications. So higher complication rate when you go for subtroch fractures. We still use it. This is my choice of treatment. It's just that when you're familiar with the complication, you can try and avoid it. There were 2 malunions, 4 repositioning or removal of nails. One had a fracture, 1 irritation, 1 limb length discrepancy. So significant complications. So I would be careful. And if you have other, implants that you're familiar with, or you like to use plates, then this would be a good choice for a subtroch fracture. We looked at 8 supracondylar femur fractures that were treated with elastic nails, and they had even higher complication rate. For these distal fractures, you have to come from the top. So these are antegrade nailing principles, where one nail is an S-shaped nail, one nail is a C-shaped nail. You do have a little bit of prominence over the trochanter. Sometimes you can get a little bursitis there. And I had one patient with infection, even after removal of the implants, the patient continued to have issues around the trochanteric bursa. So try and avoid this nail unless you're in a situation where you have to salvage, a really bad fracture. Then you should have this, in your toolbox to use anti-grade nailing. When you're using S-shaped or C-shaped nails, you don't need to bend the nail in an S shape. You still bend it just like you would bend any other nail, like a C-shaped bend. But when you're past the fracture, then you just rotate it 180 degrees, and the nails are flexible enough that it would just take an S shape. So don't try to mold or curve the nail in an S shape before you insert it. You still go in as a C-shaped nail and just turn it 180 degrees once you cross the fracture, and it would take up the S shape. As far as the technique, these are the ideal technique where you have two crossing points in the femur. You can see that there is one crossing point here, one is here. You have maximum spread at the fracture site, and you need to end just at the level of the physis here. You can go a little bit longer depending on the level of the fracture where your tip ends, but this is an ideal technique. Two nails, both are of the same size, occupying about 80% of the internal canal. As far as the forearm is concerned, the ideal technique, again, each nail occupies about 80% of the canal, 70 to 80%, and the tip of the nail should be pointing towards the other bone. So the tip of the ulna nail pointing towards the radius, and tip of the radius nail pointing towards the ulna. That is to maintain the interosseous space between the two bones. So this is how it looks after we have fixed it. And if you have an improper technique, then it would lead to some complications. In this example, you can see the nail is not crossing at just 2 points, but it's crossing at 4 points. That means there is a snaking of the nail over the other nail. It's just a sign of difficulty. There is obviously various angulation at the fracture site, along with distraction, and the nail sizes are different as well. So it's an improper technique, and then you can expect complications. As far as the insertion sites are concerned, I prefer to use a radial entry nail for the radius. There is the nerve in this area, the superficial radial sensory nerve. So I would recommend not to do percutaneous insertion of nail. I make a small incision, maybe about 1.5 centimeters, just below the level of the styloid process and at the level of the physis. And I'm sorry, just a little bit proximal to the physis. And then I don't try to find the nerve, but if I see the nerve, then I would retract it. Studies have shown nail injuries or stretch of the nerve, which can lead to numbness around the thumb. And there were more injuries related to the nerve at the time of hardware removal rather than hardware insertion, because the nerve is scarred. You go in, you can't see it. So during removal, there have been higher instances of nerve issues. This is a cadaveric dissection showing the nerve and its relationship to the other structures. I usually make a small incision, and then I would like to see the nerve retracted dorsally. Then you would come across the tendons of the first dorsal compartment, and we retract them dorsally as well, as you can see here. And then the brachioradialis, sometimes it's a tendon, sometimes it's a little bit flat. So if it's tendinous, then I would like to retract the brachioradialis dorsally as well. If it's like a very flat insertion, then I would just divide it right in the center. Then you come over the periosteum, and then you put your awl onto the insertion point, which is just around the metaphysis. You check it. Now, when you're in the direction of insertion, you need to go from volar to dorsal, not the other way around, because if you plunge volarly, then there have been reports of median nerve injuries. There have been reports of radial artery injuries. So you need to point your awl going dorsal so that you don't plunge in the volar direction. So that's how you take your entry point. As far as the nail size is concerned, we want the two nails of the same size. Each nail should be 40% of the canal diameter. And for radius ulna, each nail should be 2/3 of the canal diameter, so around 70%. We look at this patient. 13-year-old female who was right-hand dominant, had a trampoline injury and a both bone forearm fracture, as you can see here. Now, here the canal is very small, 1.8 millimeters. Usually our nails start at 1.75. You can use K-wires as well, but it's difficult to insert K-wires because their tips are sharp and they get caught into the cortex. This is still better, but with a small nail, if you get incarceration or you get jammed here, you can see what happened. We're trying to impact a nail which was not advancing because the canal size was too small, the nail diameter a little bit larger, and that led to fasciitis or significant fascial distraction. This patient did have a growth arrest afterwards. The learning point here is that if the nail doesn't advance, if you have an incarcerated nail, then don't try to just keep on hammering it. You can wait a little bit for stress relaxation. You withdraw it, you rotate it, and reinsert the nail, or you can decrease the nail size. You can also use a short nail. You don't have to always go all the way across. I would teach the residents that how long you need to be is, you measure the fracture width, and 2 times the fracture width is how much you need to be across the fracture. Once you are across the fracture by that much distance, then it's pretty stable. And the other thing what can happen with a tight nail is that at the very end, when you put your last blows to impact the nail, it can lead to fracture distraction. And that's one of the reasons why ulna is slow to heal, is because once distracted, it would take a longer time. So most of the series showing non-union or delayed union would be on the ulnar side, because the ulnar isthmus, or the narrowest part, is distal to the fracture, so it gets a little bit tight around that. And when you do your final impaction, you would distract it if you're not really careful. So just make sure before you cut the nail that you don't have any distraction of the ulna. If the nail is too thin, that's also an issue. If it's undersized, it's not going to maintain the fracture reduction. You can see that this patient had a really small nail. And what happened with this is that the patient had a posterior montagia, it's type 2. And usually when you fix the ulna with a stout Steinman pin and regain its straight ulnar border, the radius can line up itself. But in this case, the nail is not doing much except just maintaining the alignment but not keeping it straight. So elastic nails probably don't work well for montagia fractures because they are flexible. You need a rigid implant. You can either use a stout Steinman pin or a plate for this, rather than using a thin flexible nail. So this patient had revision and had some issues post-op, but not related to the ulnar fracture. An example of a 10-year-old boy. Now, this fracture pattern, the metaphyseal diaphyseal fracture junction, it's a very difficult in the sense it's controversial what's the best implant, because everything could be used here. You can put a plate, you can use K-wires, you can use an X-Fix, and you can use a nail. So everything can be used for this fracture. If you're using a nail, what happens with elastic nail is that if you try to go all the way across and all the way along the length of the bone, your distal fracture fragment is going to tilt because the nail wants to take the shape of the canal. So in this situation, it may be better to leave the nail short and not go all the way through, because a short nail like this can maintain the reduction very well, as you can see here. So I have used a short nail at times purposely, not because I was not able to advance it, but if once you start advancing, you will see that the fracture reduction would be lost as the nail is taking the shape of the canal. So I would leave it here, and then you're going to put a cast on. This patient, you can see, has a floating elbow injury, so has a supraconda as well. But just a technical variation using a short nail intentionally. There are new designs. I don't know. I've not seen this nail, but I've read about it. I don't know. A lot of times, we may get these nails sooner in India rather than in the US. But this nail design, it's not circular, it's like hemispherical, and it does have certain advantages that it decreases the malalignment by a factor of 5 and 12 in 2 planes, decrease the radiation, because what happens is that a lot of times you have to take a fluoro just to see which side your tip is or which side the nail is pointing. Whereas if you have a nail which is like this, then just by the way you grasp it, you would know which side the tip is. So it would decrease the operative time, fluoroscopy time, because you would know which side the nail is pointing based on how it looks on the outside. And it has better holding on the inserter as well. This was designed by Matozzo's son. I have a correspondence with him, and it's interesting why he came up with this idea. And they did biomechanical testing and found that this nail was better, but I've not seen it on the market yet. As far as the material, now we have both. We have implants, the elastic nails, both in titanium and in stainless steel. You need to understand that stainless steel is twice as more rigid than a titanium. So it has advantages and disadvantages. So cost-wise, of course, stainless steel is cheaper than titanium. But if you want to maintain the elasticity, the titanium is much better than stainless steel. So in this example that I'm showing here, it was difficult to put a nail through a 2mm nail, because when you start hammering it hard, the nail is going to bend because it's so elastic. Versus a stainless steel nail might be easier to introduce and insert because it can take a little bit more hammering without bending. But at the same time, you can also have issues with a stainless steel nail. Here is the stress versus strain curve showing the elastic limit, and the elastic modulus of titanium is half, and bending stiffness of stainless steel nail is equivalent to titanium nail that is 5mm larger. So the bending stiffness of, say, a 3mm nail is the same as a 3.5mm titanium nail. That means that you can use a smaller nail if you're using stainless steel and still have the same construct rigidity. When we compared the titanium and the stainless steel elastic nails for pediatric femur fractures, the malunion rate was significantly higher with titanium. That may have to do with the rigidity of the construct. So what we have both nails. So for upper extremity, I usually use the titanium nails, and for lower extremity, I would use titanium unless the patient is obese or is a little bit older. Then I tend to use stainless steel nails because of the high rates of malunion. And another study did not find a significant difference in time to union outcomes, complication rate. So I told you my preference. I don't think that it's significant increase in malunion rates, but there is some increase. So I would start to think about stainless steel nails in heavier patients. And the stainless steel nail complication is iatrogenic combination, especially if you have a spiral fracture or if you have an undisplaced butterfly fragment. I would try to use a titanium nail because of the rigidity of the stainless steel nail. You can separate that fragment, as you can see here, and that would make your fracture extremely unstable. You would convert a long oblique or spiral fracture into a segmental fracture if you knock off that piece. For the same reason, I'll always recommend that you analyze the fracture on very good radiographs and very closely to identify fracture lines that you can otherwise not see, because that would help you to guide the nail away from that fracture line when you're inserting it, so that you don't accidentally knock off that piece. So be careful, especially, it's not too common in short oblique and transverse fractures, but when it comes to long oblique and spiral fractures, there may be extension of fracture lines going beyond the fracture that is displaced or apparent. So look at the x-rays really carefully to recognize those fracture lines and stay away from pointing your tip towards those fracture planes. When you do open reduction, you need to follow the patients closely. So here is a patient who had open reduction of the ulna, and the patient had a delayed union / non-union, and at 9 months, the patient fell. Now, is this a refracture or was this a non-union? I think this was a non-union. I've never seen an X-ray with completely healed fracture on this patient. So I think it was a non-union, but you can also make a case of refracture once the fracture is healed. The non-union is more on the ulnar side. I've hardly seen a report of non-union of the radius. Most of the reported cases are of the ulna. And this patient underwent plating. If you do have a re-injury with the nails in situ with bending or displacement, there have been a couple of series where they have retained the nail, just done close reduction of the fracture and the nail, and then put them in a cast, and it has gone on to heal okay. So it's not like once you see the X-ray on the left, you have to revise it. It's not that you have to remove the nails and do something else. You can still try to bend it, as if you can get it well reduced and put it in a cast, then that's fine. This is a series of ulnar non-union. 6 patients had non-union, and most of them were in the middle third of the ulna. 5 were open reduced, 1 was an open fracture. And the middle third of the ulna has a watershed zone for the intraosseous circulation. This was noted in 1998 in this article. And what that means is that just like a scaphoid waist fracture, you have minimal blood supply, so you have higher rates of non-union if the fracture is displaced, and a similar thing here in the middle third of the ulna. Now, if you do have a non-union, what are you going to do? We had a discussion just this week about a patient which at 9 months had not healed. And one of my partners, she went and plated the patient because it had not healed. And the point was that, can we just wait if the patient is not symptomatic and the fracture is not healed? Even, because the adult definition of non-union is 6 months, that if the fracture is not healed by 6 months, it is a non-union. Well, in kids, especially for the ulna, if it is open reduced or if it's an open fracture, it may take longer than 6 months. So I wouldn't call it non-union in this particular setting. Here is a case series of 10 patients who healed at 13 months post-op. And what they have recommended is that if you see that your fracture is not healing, it may be that it's not related to biology or your mechanical stability. It just could be that it's a slow healing bone. So you can just put them in a splint and tell them not to weight bear. Of course, you can revise them, you can bone graft, you can plate it. But my personal experience is what has been reported here. I've got a couple of patients who went on to heal at around a year after elastic nailing. So they were not symptomatic. I just used a removable, like a Velcro splint on them after the first few months. And eventually it did go on to heal. So I would be a little bit careful about, labeling these patients with non-union and revising them. How about the dorsal entry? So my preference is to use the radial entry for the radius nail, but the other entry point that has been described is the dorsal entry. Now, what happens with the dorsal entry, the typical teaching in the past, or the original Nancy manual, was to bend the nails at 90 degrees, and then it was revised saying that, you should be cutting it flush or along the curve of the metaphysis so that you decrease the prominence, and because the commonest complication is prominence of the nail. So it is recommended that you leave it flush. Now, the issue with leaving it flush in the dorsal compartment at the wrist joint is that the extensor tendons are all going to slide against the tip of the nail. So we reported this 5 cases of ruptures of the EPL. One of them was my case, my patient, and that's the only one that I'd done an elastic nailing on, because one of the fellows wanted to do an elastic the dorsal entry because he had done it in the past and said this is a great technique, and we said okay. So this was early on in 2010, and then that patient had an EPL rupture. So even if you don't have a rupture, here is an example of when we went to take out one of the nails. Here you can see the amount of damage to the undersurface of the extensor tendon, and here is my patient. Then I referred the patient to my hand colleague who did a transfer, but this is the EPL rupture you can see here. Even though you can take an entry just proximal to the Lister's tubercle, which is considered to be the bare spot, the recommendation would be to bend the nail at 90 degrees. And this is what my partner Cornwall has talked about, is to bend the nail at 90 degrees so that the extensor tendons can slide around it and would not have any attrition. So this is what they've been doing at my institution when they're doing dorsal entry. I don't use dorsal entry, so I don't get the benefit of this technique. But two of our partners do dorsal entries, so they bend the nails at 90 degrees, and that prevents extensor tendon injuries. When we're talking about entry sites, I'll just point out about the tibia. You need to be careful about the proximal tibia because the tibial apophysis is coming much lower near your entry points. I always palpate the tibial tubercle and the fibula on the lateral side and go in the center, and on the medial side palpate the tibial tubercle and the posterior medial border, and then go in the center, so you're away from the tibial tubercle, not too anterior. The reduction criteria for tibia are very stringent. Only 5 degrees acceptable in any plane, just because one, the bone is doesn't have that much of a muscular envelope. Maludin is not well tolerated in tibia. It's apparent, as well as it does affect the ankle joint. So you want to be careful about your reduction when it comes to tibia. Now, an example or an article about comparing the elastic nail versus ORIF of pediatric shaft fractures from San Diego, and there was no difference in healing rates. ORIF had less angular deformities and less reoperation. Nails had lower wound complications like you would expect, and had shorter OR time. So that's another option for the tibia. If you don't feel comfortable, you can use plates. This is an interesting article about using a solid nail or a rigid nail in patients with open physis. So they have not seen any significant issues as long as the patient is nearing growth or nearing maturity. So they had 36 adolescents with open proximal tibial physis, and it was 14 to 16-year age range. So I won't do it in someone who is, prepubertal, but when they are in adolescent age group, 14 to 16-year age group, they did not have any issues with physeal arrest. 3 patients had compartment syndrome, but 14 patients did have some knee pain when they were running or kneeling. So this is an option compared to flex. I usually recommend flexible kneeling because I don't like to go through the physis, even though they have not shown any issues with deformities. I think that might alter the posterior slope if there is damage to the anterior tibial physis. Here in this article, they did not measure the posterior slope. They were just looking at overall deformities or growth arrest. And my concern is that if you decrease the posterior slope, then it may just have an effect on it later on. So I don't like to go through the proximal physis when it's open, but there are other studies as well that have, like, just even for ACL, there are a lot of studies doing transphyseal ACL reconstructions for this age group patients. So 14 to 16, 10 or stage 4 or 5, you can go through the physis. Iatrogenic fracture, especially when you're making your entry point, you can go across and create an iatrogenic fracture like you have seen here. So it's always better to use fluoro. Make sure you're not malleting against the cortex. If you're not advancing, you need to be careful, and during insertion also you need to be careful. Here is an example of a patient who had nailing for a humerus shaft fracture, and you can see at the entry site there was a fracture. Here is an 11-year-old female patient. You can see the fracture is pretty long oblique fracture, and didn't recognize the fracture line that went into the proximal fragment. And when we try to insert the nail, now here, if you try to insert nails from your normal retrograde fashion just above the physis, it may be really difficult to get across the fracture because it's so low. So this is a great case to come antegrade from the greater trochanter. So we passed one nail distally, and then the second nail, the plan was that will come from the top, like seen here. But that is when we knocked off this piece, and then the fracture became extremely unstable. So one, it was distal. Second, it was segmental, and we could not get the fracture to align or hold in spite of making attempts for about 45 minutes. So the point is that you can make a simple fracture complex, and then you can make it extremely unstable, and you may not be able to complete nailing successfully. So you need to have a backup plan. In this patient, we then shifted to a traditional ORIF. So I just opened the fracture because I was concerned that the oblique or the segmental fracture was too displaced. So we used interfrag screws here, and then we put a plate on. But the bottom line is that you need to have a backup plan for most of your patients. Like sometimes it's very simple, like a transverse fracture, and if you're not able to advance the nail, you can open it and advance it. So you might not need backup, but most of the patients, and I'm pretty sure that the setup that you're in, you would have plates and screws available, so not a big issue. But you need to have something in your mind if things don't work out for difficult fractures. The other thing is, this is a patient where I walked in the room and then one nail was across, and I said, let's look at the lateral view, and here was the lateral view. So it's completely missed the distal fragment, and the fracture was the nail was through the proximal fragment only. So orthogonal fluoroscopy is extremely important, especially orthogonal fluoroscopy at the end of the nails, because you can see this, on an AP view. You may think that the nail is in the neck and it looks good, but this is the patient that had a sciatic nerve issue because the nail has gone out posteriorly. So in the femur, because the femoral neck is anteverted, it's very important to make sure the nail is pointing anteriorly as well. Otherwise, you would go out from the back. Nail prominence is an issue and can lead to a lot of things, including stiffness, capsular irritation, and swelling, and it can also lead to infection and skin necrosis. Here is a patient who came to me treated somewhere else, and when he came, his nail was almost seen from the wound. I have one of my patients a couple of months ago had a similar thing, that the fracture had collapsed and the nail almost came out, was seen. Like if you just remove the slough, you could see the nail. So this is the commonest complication reported, anywhere from 3% to 52%. So the pretty high rate, but these were a little bit older literature. So in the last 15 years, people have recognized the complications, so they don't bend the nail too much. If you know that then fracture may collapse, you can use something prophylactic. This is how the nail used to be bent in the past. As per the manual, you can see a 90-degree bend, so that makes removal easy, but you can almost imagine how prominent or how much issues this nail could create on the skin. And so the modification is to leave it flush, not to bend the nail, leave it flush over the metaphysis, and that would make the prominence go away. Here's a 14-year-old male who had my patient. He had antegrade nailing. Now, what we didn't recognize is the end of the nail, and we were able to remove one nail at 6 months because one of the nail was pretty deep on the trochanter. We were not able to locate it when we went to remove the nail. So we said, we'll just retain it. If we can't remove it, we don't want to create big holes, and just so that we have to remove it. We always explain the family beforehand that we may not be able to remove both implants, or sometimes we may not be able to remove any implants if they're already buried underneath the bone. So there's a small chance that we may not be able to remove it. However, this patient then came back and complained of knee pain 6 months later. And then I got knee x-rays. Before that, I did not get knee x-rays because it's a femur fracture. You get femur x-rays, and there is a little bit of distortion at the knee. And when I looked at the knee x-rays, that is when I realized that this tip of the nail is just proximal to the trochlea, and it could irritate the patella, or it could irritate the soft tissues in that area. So, but that also made our surgery easy, because if it's prominent, that means it's already out of the canal, then maybe we can withdraw the nail from the knee joint, rather, because we were not able to take it out from the hip joint when we went to remove it at 6 months. And then 6 months later, the patient presented. So we just went around the knee and removed the nail, but it was prominent at the knee joint. As far as removing the nails, for pathologic fracture, when you're using it for, a bone cyst or any kind of dysplasia OI patients, you retain the nails. We don't routinely remove it for pathologic fractures, but in otherwise, healthy patients, we tend to remove the nails. Here's an example of a 13-year-old male who had a radius ulna fracture and had this nailing done. The fracture healed, but the nail, you can see both the nails are kind of buried in the bone, and so we didn't do much. Didn't let him go, and we were not able to remove the nails. But then the patient came back 4 years later with an injury, and now he has this fracture. So this is an undisplaced fracture. We treated in a cast, and the patient went on to heal okay. But two issues. One is that the nail, when it is in the metaphysis, it is okay. But when it migrates into the diaphysis, then it can erode the inner cortex, which could be a stress riser. And that happens in younger patients when they have significant growth remaining, not too much in adolescent patients where the growth may not be there, but you have to be careful. We have seen that with cancella screws sometimes when we're fixing physeal fractures, that when there is growth, the screws which were placed in metaphysis, when they migrate proximal or distal and they're in the diaphysis, then they're too long, causing irritation of tissues. So same thing here is it can erode the cortex. The second thing is that if this was a displaced fracture, it's extremely difficult to remove the nail which is in the bone. We can take advantage of the fracture site and remove the nail from the fracture, but that means that it's difficult to treat it unless you open these fractures. So that's the importance of removing the hardware once the fracture is healed, usually around 6 months. But if there is no consensus, means if someone is not taking out the nails routinely, it is okay. Things like this don't happen too frequently, so you can't justify doing second surgeries on all patients to prevent 5% of issues. This patient went on to heal okay just with the cast. 9-year-old boy, 2 years post-op. This is I showed you. And one of the tricks to remove the nail, if you can't identify the entire tip, is I use the suction cannula over the tip of the nail. I put it on and then I bend the nail to 90 degrees, and that gives me a better chance to get a good hold and remove the nail. So I use the suction tip to bend the tip of the nail all the time. We have full videos on ViewMedi, which are available for femur elastic nailing, for the entry sites for all long bones, including humerus entry sites, radius ulna, tibia. So on the cadaver, so you can look at the anatomy and make sure that you don't injure any structures, especially when you're doing it percutaneous. And then there is a symposium that was done a while back, but these are on the website. So it's based on sound biomechanical principles, and attention to detail is important. You need to, learn from all the complications and recognize and treat your complications. Thank you.
So thank you, Shital, for that lovely talk. I have heard it for many times, but I still learn something from your talk every time. So Gaurav and Meet, let's take questions first.
I would ask Meet to take the questions.
Yes, sir. So we have a question by Molin, sir. For proximal femur entry, should we take 2 separate entry points as suggested in the Nancy manual, or a single entry window is okay? And also for a proximal ulna entry, should the entry be on the ulnar side or the radial side?
So for the proximal, for the anterograde nailing of the femur, I prefer to use two separate points, entry points. But frequently, what would happen is that when you insert the nails, they may just combine, may just join, because one is that it's a little bit soft bone in that area. So you may start with two entry points, but they might just merge with each other once you finish, So if you've done a few, you would see that they always may not be two separate points. But I start with two separate points. The other one, the other question about the ulna. So the entry for the ulna is never on the ulnar side because of your ulnar nerve. So it's almost always dorsal-radial. There is another entry point which is straight, from the olecranon. Like if you want to put a Steinman pin for the Montegia, you almost always have to come right from the apophysis. The issue is irritation of the nail, when you're putting your elbow against a hard surface. But if you are going to use it for a short time and then remove it, then that's fine. Other issue is, in theory, that you can damage the ulnar apophysis. If you're going straight down the ulna. So the preferred entry point is almost always dorso-radial.
Okay. And sir, a question by Anil Agrawal, sir. What is the post-op protocol after forearm nailing, sir?
Most of the time, we just apply a splint for comfort, or sometimes nothing for the transverse fractures, which are the most common configuration. So if your fracture is stable, then we don't need to do anything. Just use a splint for comfort for the first 2 weeks, and after that you can use a Velcro splint for protection. Usually we don't cast them unless you feel like the nail is too small, the fracture is unstable, or if you just use one nail for both bone, that's also a possibility, that you just nail the more displaced fracture and you don't nail the other one. So if you just are nailing one bone, then obviously you would need a cast. If you have really proximal or distal fractures, you're going to need a cast post-op. So for the typical diaphyseal transverse fractures, you don't need too much of protection. They are stable. But if anything else, then, if it's unstable, I would recommend casting for at least 3 or 4 weeks post-op.
And when you start, when you allow them for sporting activities, Shital, for this both bone forearm fractures?
Usually when you see complete healing, which is defined as, healing on, all 4 cortices and obliteration of the fracture line. So depending on the age, but typically 3 to 4 months is the time, especially in adolescent, it takes it a bit longer to see complete healing. In younger patients, it could be, much quicker. In those who are less than 10, it could be at between 2.5, 3 months. But I tell them that there is a risk of refracture for the diaphyseal, fractures when they're going back to sports. Some of them would prefer to use a splint with activities just for, psychological, benefit. I don't know if there is any, data suggesting that it would prevent a refracture like a splint would, but some patients prefer to wear it. We also remove it at 6 months. So I tell them that, one option is to just wait till we get the nails out and then go back, because you can allow them to go back. Then there would be a 2 or 3 week interval when we remove the nail that they would have to stop sports at that time as well.
Okay. And sir, other than the eye of the enders, is there any difference in the SS nails and the enders nail?
I've not, unless because I'm not used to enders nail, I've only seen stainless steel enders nail. I don't know if they might be making it in titanium, but they are stainless steel implants, and the sizes, they are not going down. As long as I know, we used to use it for everything for adults, because I've not seen really small enders nails. So for sometimes we have to use 2 millimeter elastic nails. So I don't. Maybe Maulin can tell his experience with enders. I've not used it for the last 20 years.
Yeah. So we have minimum size is 3.5, and now there are some few companies which has come with 2.5 nails, but we don't have nails below 2.5 probably.
So, we frequently for forearm, we have to use, sometimes 2.25 nails, 2 millimeter nails. So if you're doing femur, then probably you don't need to go that small. You're usually around 3.5. So it'll work for femur, but for smaller, like for forearm,
yeah,
probably.
So forearm, we used then rush rods.
Yes, there's another
But the
option.
tip is a problem, but then we have to cut the tip and bend it a little bit.
Yeah.
Sir, another question by Molin sir. Sir, do you protect delayed unions in a brace, sir?
Yes, I use so you can call it a brace. I use a Velcro forearm splint. So it has a metal shank in it, and you have Velcro on it, and that I use that for protection if it's a delayed union.
So like a thermoplastic splint you use?
You can use thermoplast. This is not. This is pre-made. It's not thermoplast. It's a regular brace with a metal shank in it and Velcro strap. But you can use thermoplast, and I think it would be okay to. But they should be protected.
So now from last iFix, I learned that if the fracture line is not obliterated, then they can refracture. So now we advise families at the outset that we would wait till the radiologic healing for sporting activities, and some patients we put them in thermoplastic brace because they all like to play.
Same with indications for removal of the hardware. We wait till the fracture line is not visible, because we have seen that you remove the nails, and that had happened. The previous recommendations, original articles had said earlier removal of the hardware, and they had more refractures, and then the revised guidelines were to wait a little bit longer. So we usually wait for 6 months, more, mainly for the forearm. That's where the refracture rates are. The femur, we are not seeing too many issues with refractures, but forearm refractures are there. So wait a little bit longer to remove the implants.
Sir, we have a question by Dr. Chinmay Sangole, sir. Do you prefer to go for casting after nailing in forearm fractures?
Only if the fracture is unstable. Like after nailing, I think that there is more movement. I check the rotation with the nails in. I think that it's not perfect and there is movement, then I would cast it. Otherwise, it's okay not to cast them.
Okay, sir.
I think, Meet, we should stop questions here. Gaurav can ask directly to Shital later. We have two interesting cases, quick cases, and in one of them we need opinion from Shital. So Sheenam, you can share your screen. And this is just a bit of revision what Shital has taught. And a question from Dr. Kutub is, what is your experience of only titanium implants in femur? So we have been using only titanium implants in femur, Dr. Kutub. You joined late, but the indications are less than 10 years, less than 50 kilogram body weight. We can treat with elastic stable nailing. Yeah, Sheenam, go ahead. So Sheenam is our current fellow, Shital, and she would present it.
7-year-old male child presented to us with this fracture after he got stuck with an vehicle.
So Shital, like how would you read, or you would teach your fellows to read this? What is the danger point, or how would you teach your fellows about this X-ray?
So one is the amount of shortening. Like, usually when you see shortening on either pre-op X-rays or intra-op, when you do a telescoping test and you see shortening, you expect that the fracture would go in the same, displacement pattern after you fix it. The fracture, that means that there is significant soft tissue injury when you have so much of shortening. The other thing I was talking about, looking at the fracture lines closely, because you can knock off a piece here when there are long oblique or spiral fractures, and you can make it a little bit more unstable than what it already is. So in these patients, elastic nailing, I think that's what I would do, but I would be careful about your shortening part of it, because of the length unstable nature of the fracture. I see a lot of, I don't know if this is like a lot of metal debris in there. I won't be concerned about it, but they may complicate your wound healing. There might be some open injuries in those areas.
Probably there are artifacts, but what else is
Okay.
The child also had ipsilateral inferior pubic ramus fracture, and there was hairline crack in iliac wing. So it was a bit high velocity injury with significant shortening, as you can see, and there and as you can see, the third piece can separate out. So Would
I'm
you
not really sure about the inferior pubic rami fracture. It may be just the view, because sometimes you can get a synchondrosis in that area.
Okay.
This patient may have it. I'm just saying that you can
Yeah.
sometimes see the synchondrosis. It's not, and you can,
Yeah.
you may think it's a fracture, but it may be just a variation.
So the child had a bit of tenderness and swelling at that area also.
Yeah. If it's clinically
So,
correlating, then that's
but
fine.
of course that doesn't need any intervention. Now, Shital, would you fix it with TENS, or can you decide pre-operatively whether this would need something more than TENS, or it is your intraoperative decision?
It's a good point. The thing is that I have not used anything more than a TENS in any patients yet. So
Yeah.
I've got a couple of patients who have collapsed later on. If I think that they would collapse, I keep a close follow-up and I tell the family I'll see them back in a couple of weeks. And if there is a collapse, I would do something. But I have not used an X-fix or a plate along with elastic nail. And I've been able to, I'm fortunate to get away with just a little bit of a collapse. So just like a centimeter of shortening, which either the patient would not notice or, they would have time to catch up with that much of growth. So I have not used it, but I would, put them in a long like splint, maybe keep the knee a little bit flexed, so they don't put any weight on it, to protect them afterwards. So to your question, I've not used anything more than a 10. If I'm doing 10 snail, I would just use 10 snail and not anything else. But I might change in future if it seems like I have more issues, then I don't mind using an X-fix or a plate on top of it, because I've seen a lot of literature, coming out using TENS with something else. But I don't use anything besides TENS.
Yeah. So this family was a bit difficult, and I was pro using something beyond the nails. But one of my fellows gave me an idea. Can we take entry of 10th little proximal? So even if it collapsed, then also it won't cause the skin irritation. No, that was his question. But I said, no, let's do the fine way. But that's a question for you too. Can we take, do you modify your technique when you expect them to collapse?
I don't modify my technique because my issue is not a skin problem. My main issue is a collapse and a length issue.
Shortening.
That the shortening is an issue. So you're right that, maybe if the fracture collapses and I can see the tip, or the patient can see the tip, probably it may be easier for us to convince the patient we need to go back compared to the patient not seeing the tip. So that means if the tip is more prominent, if the fracture collapses, I can say, oh, the nail has backed out, fracture has collapsed, you can see it. And the patient would agree, yeah, let's just go ahead and change the nail or insert the nail again, compared to taking a proximal entry point, which you would have shortening and collapse, because that's not going to change anything. Might be difficult to convince the family. I'm just, I don't change anything. I'm just saying that it's easy to sell a reoperation if there is something which is visible.
Okay. Yeah, Sheenam, go ahead. Sure.
We applied monolateral external fixator and flexi and Anders rod placement was done in retrograde manner.
So Sheenam,
Yeah,
we found that there was a butterfly fragment. You'll see, and you can first comment on this, and then we can show you the lateral view. Can you show the lateral view, Sheenam? Sheenam has done a lot of work, but as we are short of time, I said you finish quickly. But this was the butterfly fragment,
Yeah.
And
so that is common with the long spiral or long oblique fractures. Can you go back to the previous?
Go back to the AP X-ray.
So I like this configuration because one, it's in valgus. Your commonest deformity after length unstable fracture besides shortening is a procavatum and varus. So putting the fracture in a valgus plane like this, it's beneficial. Though sometimes when you have two nails on the medial side and one the lateral, the fracture does want to go into varus. So if you have a choice of putting more nails, I'll put more nails lateral and just one medial if you have to balance it out, because I would prefer the fracture to go a little bit into valgus than varus. But I mean, the butterfly fragment is not going to be an issue if the length is maintained. That's all going to heal fine. So I'm not concerned about that.
So I saw that butterfly fragment intra-op, so I decided to put an monolateral external fixator. And Gaurav asked why not TENS and why Anders. Gaurav's patient was economically compromised. And as you can see, like in this case, it's solving the purpose, it is jamming the canal. And we have made this configuration so that it would give this stability as well. Yeah, Shinam, show the post-op. So this is probably at 3 weeks when we saw some callus on the AP view. We removed the X-fix. Go ahead. Yeah, one slide back. So this is how it healed, Shital.
Yeah. So, you can see a little bit of a lengthening on that
Lengthening.
side. So a little bit of, that's what I was saying, that if you have 1 centimeter of collapse, I'm not really concerned because it will lengthen later on because of the hyperemia from the fracture. And we have seen that even with spica and with loose nailing. If you have very tight, like interlock nail, then of course it's not going to, grow. But with the flexible nailing, we have seen, it get a little bit longer. So I'm not too much concerned about the length. If it's 1.5 centimeter of shortening in a patient who is less than 10, it would be okay.
Yeah. Next. So this is the final. As you can see.
Yeah. So a little bit of lengthening, but
lengthening is there. Yeah.
Yeah, but probably that either the patient would not notice or it would equalize with time.
This is a lateral view. And patient can do all movements, having full range of motion.
So all these patients, when there are long spiral or with comminution, I have been using X-fix, Shital, because this patients, sometimes they don't understand that this length unstable, and if nails back out, then they think that there's a fault of surgeon. So to be on safer side, we put in monolateral X-fix, and we have not seen stiffness. As you can see, all these children, they have good knee flexion and extension. And we remove
when do you remove the X-fix?
Usually 3 to 4 weeks. Once I see some soft callus on AP and lateral view. So 3 to 4 weeks is a time where we see this callus. And once they have
any
X-fix.
pin track infection or any issues have you seen?
No. And we have not seen that. And once we put X-fix, then we do not put an back slab also. Splint also we don't give. We just put a pillow underneath the X-fix and support the limb in neutral position. That's what we do. How much Jaideep, as Shital, and Shital can tell how much time we should wait for limb length discrepancy which has happened.
Well, it might not get completely resolved, but you can see the trend in a year or in the 1 to 2 years. You will see a trend. If it's already catching up, then you don't need to worry about it. If it's staying or worsening, then you know that you have a problem. But usually, between the first and the second year, you will see that it is resolved. Most of the time, it resolves. Anything less than 1.5 centimeter, it's fine. When it comes to 2, then it's an issue.
Yeah, so we see the same thing for osteomyelitis. We see lengthening of the limb after treatment, and most of them, they recover or readjust with the time. Now, Gaurav's question, sometimes after putting the TENS, I found instability, so I use X-fix along. My question is how we can judge when child is under anesthesia that it is stable, Sometimes we see that once child is awake, with the muscle movement, it collapses. So my question is,
you can do a test. You can do a telescoping test after you have inserted the nails, and you can see if there is shortening or not. Or if you're really cautious and you think it is already unstable, then you don't do anything but protect the patient. That means you already know it's unstable, because before, even if you don't do shortening, but you think that I'm very certain that if I do shortening, it is going to collapse, then I'm very cautious. I explain the family, I put them in a posterior splint. I make sure that they are non-weight bearing, but it can still collapse. As I said, I just had a patient that had collapsed. I didn't do anything. I removed the nail because it was at 3 months, but the patient is about 1.5, 2 centimeters of shortening, and this is one after like 2 or 3 years. So I'm concerned. The patient is young, 7. So I think it would, I've explained that between 1 and 2 years, it would catch up and we don't need to do anything. I just saw the patient yesterday at a 5-month follow-up. And patient is doing fine. I mean, once the fracture is healed, they don't have any pain, but they do have, when you notice them walking, you would notice the limp, which the family says getting better. So it's going the right direction. But that's why I'm saying that I might change. I've seen more literature about, doing something X-fix or plate, for length unstable fractures, but I have not done it. But that would be your thing, is put an X-fix on. It doesn't take too long. It has shown to be, a pretty good alternative to not, to shortening. So might be a good idea to do that.
Fine. Thanks, Shinam, and sorry for cutting your presentation a bit short because we are short of time. Thank you very much. Meet, can you share your share your presentation now? Thank you, Sheena.
Yeah, that was a good case. Thank you.
And now, Shital, this is one of my pediatric colleagues' nephew who fell down. And yeah, Meet, you can start your presentation.
Yes, sir.
So Dr. Meet is the second fellow who has recently joined here.
So we have a 9.5-year-old male. He had a history of fall from a bicycle and presented to us within 4 hours of injury with pain and swelling and visible deformity of the right forearm. So we performed the X-rays, and this is what we found. As we can see, it is a closed mid diaphyseal fracture of radius and ulna and with an apex dorsal angulation.
So just a few questions. So Shital, now how would you approach? Now this is a borderline age, 9.5 years. Physically, child is little bigger. The canal also is bit narrower in one of the planes. I barely see a canal. So what would be your choice of treatment?
Is it a closed fracture?
Yeah, it's a closed fracture.
Yeah, I would nail it based on the amount of displacement that the patient has. I would prefer elastic nail. I mean, your option is to do a close reduction, but patient is bigger patient, then it might be difficult. It might be a concern about compartment syndrome. Though even with elastic nailing, your compartment syndrome risk doesn't change too much. You still have to make sure you observe this patient for 24 to 48 hours, especially if it's a high velocity injury and a displaced injury. So that you have to be careful about that. But once 24 to 48 hours are gone and the patient has done well, then my preference, I think you can always try a close reduction in any fracture, but my concern would be that it might not stay with the bigger forearm, bigger kid. Then elastic nailing would be a good option.
Now looking at this canal at the diaphysis, Shital, I don't know whether you can see it well or not, but in ulna as well as radius, the canals are very thin and hardly made.
Yeah, so that happens sometimes in refractures as well, not in this case, but in refractures, you hardly have any canal. Then you have to think about your, the plating part of the plate. You can plate them if the canal is significantly thin. But, here, I think you can still pass. It's, we have really small elastic nails. I still, I'm not able to use K-wires very well because of the tip. It almost always gets caught. But we have, sizes going down to like 1.75 on elastic nails. Yeah. And so that is almost as good as a 2mm K-wire. So, I think I'll be able to pass that one. But if I'm struggling, my backup would be to open and plate it.
We have some of these children which are physically very strong, but their bones are very narrow. The canals are very narrow, and just putting 1.5 mm rush rod would be kind of very flimsy for that stature of child. But they are at the borderline age, so I thought that I would conserve him, and we'll show you the sequential X-ray, and you can guide further. Yeah, Meet, go ahead.
So this was the immediate post-op X-rays. We had
So-
given a upper elbow cast in the mid-prone position.
So Shital, what do you think about this reduction? I tried to make this ulnar border straight, as you have always taught us that you keep this ulnar part straight, and the cast index we try to maintain, and the contour of skin.
Yeah, I mean, it's it looks okay right now, but based on the way I'm seeing it, it's likely to fall. The radius is going to fall into it. It seems like it would be one is the level, second is the same both fractures are at the same level.
Same level, yeah.
It is likely to go into the interosseous space, the radius fracture, as the ulna kind of angulates a little bit dorsally, which are typical fracture angulations. So you have to watch them closely, and we can see if it maintains, if this is what it's going to be at the end, it's going to be fine, but it might keep on moving a little bit.
And now, as you can see, that I have to apply the cast in mid-prone in order to have the best alignment. And we had this discussion in iFix that we should give it in supination, or a little more supination than mid-prone. So
no, I mean, I think neutral to, I think this is fine. I mean, it's holding pretty good, so I would not have done anything different. I like to do neutral cast for most of the patients.
Right. So let's see how it goes. Meet, you can go ahead.
So these are the X's on the 4th day post reduction.
Yeah,
So
still acceptable, but you can see, when it starts moving is when you are concerned that it would keep on moving. Okay, so. And the reason one of the reason I said to fix it early on is also because of the fracture level. So we have changed our practices, for radius that is, in the proximal half, we are more, aggressive about fixing those, because you look at multiple papers, and that is a risk factor for, displacement after reduction is the level of the fracture, because it's difficult to maintain these fractures, especially when you say it's a big forearm. It's difficult to maintain even with a well-placed cast.
All right.
So, it is acceptable here, but if it drifts more, then it's an issue.
So, so this is 1 week, and
so you see the one on the right side is what I'm concerned about, is that the ulna is drifting, the radius falls into the interosseous space. So now you have to fix it.
Yeah, so this, so I called him that we may do a wedging, or we may plan nailing, and the child, they are giants, and they had this pollution and all, and they came 1 week later. So Meet, show the last X-ray. So this 2 views, and 2 weeks, I think this is holding. I could see on my digital, there's X-ray with magnification that shows some callus in both the plane, and the skin contour underneath the cast is looking okay at this point. So
did you change the cast? Did you reduce it?
No, I have not. Actually, I have told them that you come NDM, I might do a wedging, or I might change it. And if I was still worried about the canal of radius and ulna, so I called them. But this was the X-ray, so I have not changed the cast. They're the same.
Interesting, because the one that was on the previous X-ray showed more displacement than this one. So something.
So there, we took 3 X-ray in different rotations, and one of the X-rays showing, but this is the pure AP and lateral views, where it looks, the skin contour, if I just neglect the bone and see the skin contour, it looks okay at 2 weeks.
Yeah,
and with
no, it
some
does look
shallow.
it does look okay on this one, but it didn't look okay on the
Yeah,
one
yeah,
before.
that was an oblique view.
Okay.
So
all
what
right.
I have now planned is I will call the child next week and I will do it, check him under image intensify and apply plaster in about 20 to 30 degrees supination so that this child does not end with restricted supination, or I mean, he must have functional supination and pronation he can compensate from the shoulder if at all it ends up into a kind of malunion, you know. What would you do? I mean, would you?
So I mean, so yeah, I do a similar thing. You know, when I am in doubt whether I need to fix or whether I need to continue, I don't even take them to the OR. I take the cast off in the clinic and I
Yeah.
keep them, keep the arm, with me all the time so that there is no significant movement.
Yeah.
Because I don't want them to move too much once the cast is taken off. But I carefully remove the cast. I check to make sure that there is no visible deformity and then there
Right.
is no hard block to rotation. So, usually at around 2.5, 3 weeks, because then there is a little bit of soft callus. So then I just rotate the forearm and check it. If I don't see a hard stop, like, that there is significant stiffness, then I know that, it would be okay. But if
Yeah.
I don't, get to move it, so I do examine them clinically when I'm in doubt what I need to do. Take the cast down and check them in the clinic without taking them to the OR, because once you're in the OR, you're tempted to do something, that, if you're putting the patient to sleep, then the issue is whether you can,
Right.
cast it. And, we looked at consecutive patients that were re-reduced in the OR without nailing, and they did well, because when you put them, between 2 and 3 weeks, you can get a really good cast on. Swelling is down, the fracture is already glued. So when you do revision casting in the OR, you don't have to nail them. But that is the issue, is that a lot of people would nail them once they take them to the OR. But we published our redisplacement and recasting for these patients who are like borderline. You can get a little bit better correction without doing surgery, but under anesthesia. But to make that decision, I would kind of, unless it's significantly off, like, you check them next week. If it's off, you got to do something. But if
Yeah.
it stays this way and you have seen one bad x-ray, then you think in an oblique view, it might be, worse than what you're seeing on AP and lateral. Might be worth taking the cast off and checking them clinically how things are, and then making a decision.
So I was thinking to take him in OR and do recasting, a bit of supination, but now I can take it in clinic. So when you take plastering off in clinic, you get X-ray or you just check the
not without the cast. So you can get an X-ray before you take it down.
Okay.
Because if you see obvious displacement, then you are going to do something that you would not be able to do in the clinic.
Right.
But
right.
if the X-ray is the same, and then your concern is that because you had seen one bad view, your concern is that what if that is the real, obliteration of the interosseous space, and there would be stiffness. So if it looks like this, then I would just take the cast off in the clinic and check the rotation. And then, if the rotation is good, then you just put another cast on. You don't have to take them to the OR. But if the X-ray looks really bad, or clinical examination shows that there is stiffness, then there is only a 1 week window. After that, once it is healed, then it's going to be difficult to reduce.
Yeah, so that's a plan, and we'll update you, Shital, how it
that
goes
would be
from
good.
there. So
okay, interesting.
I think thank you very much.
Yeah.
With that, we come to the conclusion of this nice session, and I must tell you, Shital, we usually have 20, 25 now. Many people, general orthopedic surgeons from Ahmedabad and Gujarat, they have attended your presentation, and through Ortho TV, it is being telecasted live, and many more orthopedicians would have benefited from your talk. And we keep your we keep your presentation on our YouTube channel so that many people can see later on. So
no, it is great. I mean, it's fun to discuss cases. It's always good to be back with everyone, and nice sessions.
Thanks, Shital. Thank you very much.
Thank you. Okay, bye-bye.
Bye-bye. Thanks, Meet, Sheenam, and Gaurav for your wonderful work. Thanks,
Thank
Shital,
you,
for your
sir.
valuable time.
Thank you all.
Take care.